A very good evening to one and all. I, Amit Vijayvargiya, on behalf of Mankind Pharma, welcome all the delegates who are present today with us in our Treat Fit Early Module 4. As per the Ministry of Health and Family Welfare, food care is the most neglected area in diabetes. Based on this observation, Mankind Pharma has taken an initiative of Treat Fit Early Food Care in Diabetes. Also, I would like to introduce you to our esteemed speaker of the evening, Dr. Prashant Agarwal, Medical Advisor of Mankind Pharma. Before commencing towards the enlightening session, I would like to take you through the journey of Mankind Pharma in industry so far. Mankind was established in 1995, founded by Mr. R.C. Juneja. Mankind is ranked 4th value-wise. Mankind has a strong presence across prescription drug, OTC, veterinary medicine. Here in Mankind Pharma, our philosophy is serving life and stand on its 3 pillars of quality, affordability, and availability. Mankind has a strong presence over all major therapy areas and leadership in many. With this, I would like to thank you for joining hands with us in our Treat Fit Early initiatives and hand over session to Dr. Prashant.
Thank you, Amit. Let me share my screen first. A very good evening to all. So here we are at our last module of this Treat Fit Early program. You have been with us in last 3 modules. Now, this is the 4th one where we are going to discuss in totality what is diabetic foot disease, what are the variations, how to diagnose, how to screen, and how to manage. Now, I guess you are already aware about the magnitude of this problem of diabetic foot disease, right? I mean, around 15% of the patient with diabetes, sometime in their life, they are affected with this problem, right? The prevalence of this disease actually ranges from 1% to more than 10% also. And if you see the incidences of foot ulcers in diabetes, that is actually approximately more than 2% per annum. And these foot problems actually account for 25 to 50% of all hospitalization in patients with diabetes. And diabetes is the leading cause of non-traumatic lower limb amputation in the world. And mind you, this is preventable. That is the most important aspect. Still, it is the leading cause of non-traumatic lower limb amputations. Globally, if you see, around 1 million or 10 lakh lower limbs are amputated every year due to diabetes. Every 30 seconds, there is a 1 limb is lost somewhere in the world. In India, if you talk about, there is a rough estimate that around 1 lakh lower limb amputations are lost every year. And see, 75% of these amputations are neuropathic, which is completely preventable. How it happens? So, uncontrolled diabetes is the center, right? Then we have large and small vessel disease can happen in patient. Then maybe chronic sensory and motor neuropathy occurs. Then due to some infections, local deformity can lead to trauma. Along with trauma can lead to ulceration, and ulceration can ultimately lead to amputations. So what is, the neuropathy? Neuropathy can lead to lack of protective sensations, right? Insensate foot. So there is no sensation in the foot, which can lead to injuries which remain unnoticed. So that is why usually patients do not complain about neuropathy. So it is important to observe their foot, inspect their feet every time whenever patient visits to your clinic. These motor neuropathy can cause loss of power of muscles in thighs, legs, feet, which can lead to different deformities. And these deformities lead to development of abnormal pressure points over the foot, where calluses can develop and can lead to Charcot foot deformity also. If there is autonomic neuropathy, which can lead to reduced sweating, dryness of skin, fissures in the skin, and can also lead to microvascular dysfunctions. Now, what is callus? As you know, this is the callus which formed due to repetitive mechanical force, repetitive pressure and at a particular pressure point, and it can lead to callus formation. Now, these callus are formed, it means the blood flow is adequate, means these are neuropathic ulcer, neuropathic deformity, neuropathic diabetic foot disease is there. So that is why the blood flow is completely normal. The thick callus, they can press underlying, they can press inward, which can create neuropathic ulcers in that place. If callus is not removed in time, it can lead to tissue necrosis or leading to neuropathic trophic ulcer. So this is the place of a callus. Now, after the removal of callus, you can see there is an ulcer which is formed inside the skin. Now, sensory neuropathic ulcer, like this is a toe ulcer, they always develop at the pressure points. So whenever there is a pressure, they develop at that place only. Neuropathic foot can lead to various deformities. So if there is a motor neuropathy, means there is a muscle weakness and all, it can lead to hammer toes kind of deformities, right? And we can see distended veins also if there is an autonomic neuropathy. Then we can see, of course, along with loss of sweat, dryness of skin, we can see distended veins at the foot of the patient. See, these all signs, I mean, signs we need to check, we need to observe every time we are looking at the patient's foot. Now, Charcot neuropathies. Charcot neuropathies are usually relatively painless, progressive, and degenerative orthopathies. And many of the time, what happens, because the pain is not as much, so usually patient ignores these deformities, and patient actually comes whenever the deformity is set in. There's a permanent deformity, then actually patient comes to know that, okay, there is something wrong with their foot. So that is why it is really important to observe for any signs of these neuropathies. Right? So Charcot neuropathies patient can present in acute stage or in chronic stage. In acute stage, what happens? The foot is hot, swollen, erythematous, because blood supply is intact. So that is why the foot is hot, the temperature is slightly raised, and erythematous. Bone crepitus, the sound between two bones, when you crack your knuckle bones, you hear the sound. The same sound can be heard during this Charcot neuropathies. Pain, as I said, usually it's a relatively painless, means what you are observing, a red swollen foot, but accordingly pain is not there. Pain will be there, but not that much high pain relative to deformity, relative to the hotness or the swelling. Patient may recall minor trauma. Patient may give you history of a minor trauma, and the commonest site is midfoot, followed by metatarsal phalangeal joints and ankle joints. Now, if patient ignores this acute stage, it subsides on its own after there, because then the deformity sets in. Then comes the chronic stage. So patient present with various deformities, including flat foot or rocker bottom foot. Usually vascularity of the foot is good and pulse may be bounding. So you will see bounding pulse and quite good vascularity, means erythematous foot you can see. See, this is the Charcot foot, typical. As you can see, there is a deformity already set in, right? And in the X-ray, you can see various fractures, healed or current fractures you can see. How to assess? So there are 4 stages which we can divide. So 0 is the prodromal, means there is a dermal flush, redness, increased skin temperature, with or without local edema. X-ray evidence may or may not be there at that time. Now, the acute stage start where acute destructive period, which is induced by minor trauma, resulting in fragmentation of bone and joint dislocation or maybe subluxation. Now, this is one of the most important stages to recognize, because at this stage only the deformity is not yet complete, not permanent. So it can be arrested over there only. And of course, we can prevent further deformities in the patient. Then comes the subacute stage with the edema lessens down, fracture starts to heal up. Then the reconstruction means there is a abnormal joint of abnormal healing of the fractures, which can lead to deformity. Now, there is another term, peripheral vascular disease. That is usually due to atherosclerotic occlusion of lower limb arteries. Means now it is the ischemia which is developing in the foot. Earlier, we were talking about typical neuropathic ulcer. Now we are talking about ischemic ulcer. That is due to peripheral vascular diseases. So if there is an occlusion of the arteries or the vessels in the lower limb, which can decrease delivery of oxygen and other nutrients, right? And patient usually gives history of intermittent claudication, right? Intermittent claudication means patient walks to a certain distance, then the patient foot start having pain, severe pain, so much severe pain that patient cannot walk further. Patient has to sit down, relax for a bit, for a few minutes, and then again patient is able to walk for a similar distance. But over the period of time, this distance started reducing, and patient even can have a resting pain in a severe case. You can see loss of hair, atrophy of skin and nails in the patients. There is a history of poor healing of foot injuries, infections or ulceration also. And this can lead to necrosis and gangrene in the longer run. So this is peripheral vascular disease, ischemic foot. You can see the blackening of the skin, right? This is a typical sign of ischemic foot ulcer. As you can see, necrosis and gangrene also setting up. So diabetic foot ulcer, usually it's not a single type. They can be neuropathic, they can be ischemic, and there can be a category where both the neuropathy and ischemia both are there. So it is really important to actually differentiate among the neuropathy. Sorry. So it is really important to actually differentiate among the foot ulcers in a diabetic patient. How can you differentiate? It's very easy. If there is a sensory loss, it may be neuropathic. Pain will be lesser in comparison to ischemic. I'm sorry. In ischemic foot ulcer, there will be pain, right, which is either absent or very mild in neuropathy. Callus can be present in neuropathy, and ischemia, necrosis will be common. In neuropathy, because blood supply is adequate, so what you will find, the fresh, the healing kind of ulcer. But in ischemia, you will find non-healing type of ulcer. Foot temperature, warm in neuropathy, but it's cool with absent pulses in ischemia. So in neuropathy, you will find dry skin, fissuring, but in ischemia, it will be a typical sign of delayed healing. And typical location, neuropathy usually occurs in the weight-bearing places. Wherever there is a weight, right? There is a stress, only there neuropathic ulcers occur. But an ischemic ulcer, you will see it occurs on the distal end of the artery. Then there is a third category where mixed type of sensations, wound bed and anything can be present, like neuroischemia, where both the conditions are there. There is a neuropathy and there is a ischemia also. Yeah. So as you can see, the neuropathic ulcer, typically you can see reddish, red ulcer bed is there. See here also pinkish red granules are there. And see, check the location. It at the pressure points. It's on the pressure points. While in ischemia, as you can see, there is a pale, darkening, blackening kind of ulcers are there. And these ulcers usually at the distal end of the artery. So come to foot examination. How to evaluate? First of all, very important, general appearance of the foot. You don't have to do anything else. You simply ask the patient, remove the footwear, put the foot on a stool or in a well lighted area so that you can observe for size, shape, color, and you have to compare both the foot. I mean, not a single foot, you have to compare both the foot simultaneously. Check for pressure point calluses, corns, check for any deformity in the nails and all. Then comes the examination part where you can check with monofilament, ankle jerk for any motor neuropathy, vibration sense again for the motor neuropathy. Then you can check for the peripheral pulses for the ischemia. So this is a typical ankle jerk. Then this is the vibration sense, which I guess you are already aware, so I'm not going to detail. Now, very important aspect is that of this examination is monofilament. Monofilament, the touch of the monofilament is actually it's a very basic examination. You can have monofilament with you all the time, and you can simply check for the pressure sensitive areas in a foot. Now, how? There are 10 places, 9 at the bottom of the foot and 1 at the top of the foot, right? So accordingly, you can simply pinpoint, you can put the monofilament, ask the patient yes or no, and record all the results as a plus, plus, plus. So there are 10. So out of 10, how many pluses are there? Accordingly, you can, if it is 10 out of 10, it's perfect. There is no loss of sensation. But if 9 out of 10 or 10 out of 10 or maybe 6 out of 10, so accordingly, you can judge the severity of the disease. So this is the monofilament, and you can simply, you have to test accordingly on the 10 sites. Probe to bone test, see that actually helps into diagnosing the osteomyelitis, because there are ulcer, and ulcer, as I told you, the pressure points, these neuropathic ulcer, because of the pressure, they can move inward and can involve bones in the later stages. So by probing, you can detect whether bone is involved or not. Now, if you come to laboratory investigations, so of course, sugar level, X-ray is very important. Biothiometry, you can do if you have pus culture sensitivity, if there is an ulcer. Peripheral Doppler study, if possible, please go ahead and do it. Then you can move ahead with a specialized like angiography and duplex Doppler ultrasound also to check the extent of the ischemia or extent of the disease. For to check the ischemia, because in ischemic ulcer, definitely there is a peripheral vascular disease and there is a blood, there is a low flow of blood. So to check that, you can go for Doppler ankle brachial index. It's a very simple thing. It's a ratio of ankle blood pressure to arm blood pressure. So foot and arm blood pressure is a ratio which comes, and it should be more than 0.9. 0.9 to 1.4, it is absolutely, patient is normal. But if it is less than 0.9, then you have to think for the ischemic vascular disease in the patient's foot. This is biothiometer, which I guess you are already aware. Now, radiology, diabetic osteomyelitis, you can see in this X-ray, and Charcot foot, the typical deformity, Charcot foot can be seen here. Now, how to evaluate ulcer? So there is a Magid-Wagner classification, which is very common for the diabetic foot ulcer, 0 to 5, which I will show you in next slide. Yeah. So grade 0 means there is no ulcer, but patient is of diabetic foot disease, means patient is of high risk, but ulcer is not yet developed. In grade 1, superficial ulcer is developed, right, involving only the skin, not deeply penetrating. Now in grade 2, it is a deep ulcer penetrating through ligament and muscle, but no bone. Bone is involved in grade 3 along with cellulitis or abscess formation. Grade 4, when there is a localized gangrene, and grade 5, when this gangrene is involving whole foot or maybe more area. Now, to manage this diabetic foot, a multidisciplinary approach is required. And what is this? It involves various specialties. Of course, diabetologists, diabetes practitioners at the center stage, but along with diabetologists, you may require the need of general surgeons, vascular surgeons, orthopedic surgeons, educators, orthotists, interventional radiologists, and podiatrists. Comes to the basics. So A, B, C, D, E, F of a scheme for the goal settings. Now, how to this goal setting? A1C, HbA1C, it should be less than 7%. B, blood pressure, maintain a blood pressure control target of 130/80. Cholesterol, aim for LDL target of 70 to 100 or below 70. Drugs, start for all the drugs which are important, which are required, like for the lipid control, for the blood pressure control, for the cardiac control. I mean, all those drugs should be prescribed in the patient. Regular exercise is important. Foot care, very important. And cessation of, means stoppage of smoking and stress are also required. Diabetic foot management. So if there is a normal foot, right? Normal foot means when we are saying normal foot, there are risk factors, right? Patient is of diabetic, diabetic patient is there, but risk factors are there, but there is a normal foot, no sensation loss, nothing, right? There may be internal, maybe there are chances that disease has already started, but not showing up at front. So what you have to do, you have to arrest here only. Proper lipid control is needed, proper glycemic control is needed, good foot care practices are needed. Then comes the high risk foot, means now the risk is very high, means patient may be having high blood pressure, patient may be having raised lipids also. So patient is now at high risk. So again, what we need to do? Proper footwear, chiropody for corn calluses management, metabolic control, patient education, and good foot care practices. Now, most of the time, I mean, there has been a question about the how to ease out the pain of diabetic neuropathy. So for pain, there are various things, but before I go to this diabetic neuropathy stage, at this stage only, I want to discuss one more important aspect about because there have been many questions about the vitamin B12, methylcobalamin, whether it works or not works, right? See, all the vitamins, minerals, methylcobalamin is very important for the neural growth or neural balance or the neural nutrition point of view. It is very important vitamin. But the problem is that we start vitamin B12 when the disease is already set in. See, B12, it can prevent, it can reduce the progression, right? But if you want to actually work, you should start vitamin B12 in a diabetic patient in the early stage. Means whenever you are starting anti-diabetic medication, start vitamin B12 if needed. If needed means usually in India, I mean, generally we consider that all the, because vitamin B12 can be taken from the nutrition, from the diet itself. But nowadays, as we are already aware in our diets, whatever fruits, vegetable we are eating, B12 is not that much. So there are high chances your patient is already vitamin B12 deficient. Ideal way is go for a B12 testing. If there is a deficiency, start B12. But there is a general rule because it's a water soluble vitamin. So at a constant, I mean, as per the RDA requirement, we can provide vitamin B12 to those patients at the start of the diabetic management because it has a role in prevention, right? It is a preventive. So if we start early, then we can actually prevent the disease happening and of course the progression of the disease. Now comes to the pain part. So to ease out the pain, you have various medications. So like gabapentin, pregabalin, or maybe amitriptyline, nortriptyline. As per depending upon the patient's severity of the pain, you can give any medication. That is up to you which medication you part. Generally, we start with either gabapentin or pregabalin. Then later on, we might add nortriptyline or amitriptyline. If not possible, if not happening again, then we can go for further like norepinephrine reuptake inhibitors like duloxetine and all. Then lidocaine patch locally, it's a local anesthesia. anesthetic, so that can also be given. Finally, we have opioid analgesics also like tramadol or oxycodone, which can also be given to the patient. Now, let's go for one case study. So it's a 60-year-old lady with diabetes for the past 20 years, presented with a painless swelling. So it's a typical painless swelling of the ankle joint with bounding peripheral pulse. I guess many of you have already guessed what it can be. Now, this is the X-ray and this is the physical appearance of the patient's foot, and this is the X-ray. So, as you might have already guessed it, it is a Charcot foot. It's a Charcot foot neuropathy, the patient. Management of Charcot foot in acute stage, immobilization, because we have to reduce the pressure on the foot. So immobilization is the most important aspect. Total contact cast can be given. Stress reduction, no weight bearing altogether, no weight bearing. Intravenous bisphosphonates sometimes help, so it can be given. If there is a chronic stage, then deformity has already set in, right? So what you can do, orthotic management with footwear and insoles and all. If there are recurrent ulcerations with fixed deformity, indicates need for the surgery. So refer the patient for the surgery. Now, so approach to stage 3, the ulcerated foot. So if there is a neuropathic ulcer, then it's very simple. Offloading means you have to reduce the weight on the ulcer part. If there is a neuroischemia is developed, you have to start with managing the revascularization of the patient foot. So you may require help of general surgeon or maybe vascular surgeon for that part. As you can see, if I'm talking about once in a neuroischemic ulcer, as you can see here, this femoral artery is actually blocked, right? You can see the reduction is there. There is a blockade here. Now, after the angioplasty, you can see the blood flow is completely intact. See, this is the patient with the subplantar abscess, deep calcaneal lesion, as you can see. So, what when it was seen in the angio, the multiple crural lesions and the blood supply to that part, popliteal part, was actually reduced. Now, popliteal bypass was done, and the blood supply to the foot was restored, and you can see the healing of the ulcer. So, in neuroischemic ulcer or ischemic ulcer, it is really important to first differentiate neuropathy and ischemia. If there is ischemia, please refer the patient immediately to vascular surgeon, which can actually restore the blood supply and which can ultimately heal the ulcer. Skin grafting, and now in the severe cases, because there is a skin necrosis can happen in ischemia. So skin grafting is the one part which can be used. See what happens, the necrotic skin is removed so that it gives time to heal the fresh skin below the necrotic skin, right? And the fresh skin can be grafted to the injured or the lesion area. Now we come to stage 4, where the foot is infected. So it is very important to do the microbiological control. Microbiological control means you have to use antibiotics, right? Do not wait for culture to start antibiotics. If you have a suspicion, you have in diabetic foot, I'm talking about, I'm not talking about in general, I'm talking about in diabetic foot. If there is an infection, you can see the infection is there, pus is there. Do not wait for the culture. Start as far as possible, start antibiotics, right? If there is a non-limb threatening, if there is an ulcer which is superficial and all, you can start with general amoxiclav or metronidazole or ofloxacin metronidazole and all, right? If it is life threatening, limb threatening, means there's a deep ulcer or maybe some deep osteomyelitis is occur, then you may have to start with multiple antibiotics also to provide the broad coverage to the patient. So this is what I am talking about, the example of superficial infections, right? Now this is, I'm talking about the deep ulceration where limb or life is threatened for the patient. In those cases, start broad spectrum antibiotics together. See, this is osteomyelitis, which has set in. Now, weight bearing in neuropathic ulcer, as I was telling you, it is very important to offload the foot, right? And to offload the foot, the best thing is total contact cast. There is not so whatsoever pressure is there, we have to remove it. So total contact cast is the perfect example of offloading. So please provide this option to the patient. If not possible, removable cast walkers can also be there, where patient can remove the cast during the sleeping time and all. But if there is a severe ulcer or severity is there, then definitely total contact cast is the one which you would like to suggest to your patients. So this is total contact cast. It can be done for toes, for forefoot, for midfoot, for heel also. So this is the gold standard, still the gold standard, and reduces the pressure under ulcer site between 84 to 92%. Till 92% that pressure can be reduced with the help of total contact cast. And these are custom made, so it is very easy. It can be customized to the patient's need. And the healing time, it is actually shown the shortest healing time of 8 to 12 weeks. So remind you, you have to educate your patient that please be patient, take control, because these things take time. And this is the shortest time, 2 to 3 months. It is the shortest time to heal a neuropathic ulcer. So please educate your patient accordingly. Then nowadays we have different types of cast also, like removable cast walker, instant total contact cast is there, right? They are having their advantages, disadvantages. But again, total contact cast is something which remains gold standard. But usually patients are not very much, it needs required training also. So there are different things which are available, which can be utilized to reduce the pressure. Like half shoe for the forefoot, right? If there is only forefoot, you want to prevent only forefoot and toes, then there is a half shoe. Then half shoe for the rear foot. Surgical shoes are there. Over the counter walking footwear, generally they are very affordable and easy. So you have to tell the patient to have a good heel, right? The padding should be there inside the there to reduce the pressure. Then footwear modification, rocker toe and all. So there are various custom made shoe companies are there, which can make customized shoes for your patients. Then right, custom made footwear, custom made orthotics, the insoles which are available, which can be applied to reduce the pressure and all. Metabolic control, very important, right? That we not need to remind this thing to our patient that it's very important to have a proper glycemic control. If oral drugs are not helping, please do not hesitate to put your patient on insulins. Insulins are better if there is an infection, right? And patient is hospitalized. If hospitalized patient, it is always good, always better, and all guidelines says put the patient on insulin to have a better glycemic control instantaneously. Now, if there is a necrosis, which has necrosis already occurred, so if there is a neuropathic foot, severe infection can lead to necrosis. So surgery is almost always indicated. You require surgery. So please refer your patient immediately to a surgeon. If there is a neuroischemic foot, right? So as far as possible, surgery is delayed till the vascular control is achieved. Means in a neuroischemic foot, what we have to try to have a proper blood flow to the artery. So angioplasties can be done. So again, you have to, in a necrotic foot, you have to refer your patient to a vascular surgeon or a surgeon. Now, how to prevent this diabetic foot problem, right, in our patients? And also there are 10 commandments of diabetic foot care, which you need to educate your patients. First, do not walk barefoot. Inspect the feet daily for blisters, wounds, bleeding, or any foul smell. Do not apply hot fomentation or cold compress or electric heating pads, right? Use correct footwear. Choose your footwear after consulting your doctor. Always wear footwear with socks with loose elastic. Do not walk bearing weight on the affected foot in case of there is a wound or after surgery. Do not sit cross-legged for a long time because it may lead to reduction in the blood supply. Do not remove footwear during travel and place your foot on hot objects. Cut the nails regularly. Nails should be cut straight across because to avoid any injury. Do not cut corns, calluses with blade or knife. Home surgery is dangerous. Always ask your patient to consult a doctor first and then only. Clean the feet twice a day with soap and water. Wipe the web space dry and apply softening agent to feet. What are the strategies to saving the diabetic foot? First of all, correction of vascular risk factor. See, if there is atherosclerosis, you have to go for the lipid controlling agents, right? Improve the circulation. Regular foot inspections are important. Treatment of foot ulcers, localized treatment. Prescribing special shoes. Teamwork among medical disciplines. So you may require help of surgeons. You may require help of an orthopedician. Patient education is again very much important. In the last, a multidisciplinary approach is mandatory, right? For early diagnosis, proper evaluation, managing diabetic foot, and all this can actually lead to reduction in amputation rate. Your one step of checking feet regularly of your patient can actually reduce their chances of getting amputated. So it can actually save limbs of your patient. So please do it. So that's all from my side for today evening. Now, if you have any queries or any questions, please you can ask.
Dr. Prashant, thank you so much. And as we have come to an end of the session, I would like to thank our esteemed delegates who have joined hands with us in our initiatives of Treat Fit Early Foot Care in Diabetes. And before closing the session, I would like to request our flag bearers to please mention, inspect your feet daily on diabetic prescriptions to drug awareness for foot care. So thank you so much. And Dr. Prashant, there are a few questions from our delegates as well. So the first question is there, what is the positive and negative monofilament test? So could you please help us in this?
See, it's a whenever we are testing any with the use of monofilament and all, see, so you have to check the positive and negative responses. So out of 10 sites which I told, you have to ask the patient whether patient is able to judge the sensation or not. So record the number of positive results. Like let's say you tested 10 sites or 9 sites, whatever, and patient actually were able to say yes for 6. So patients, the scoring should be 6 out of 10. So same way, it's a positive response which we calculate. So 6 are positive, 4 were negative.
Thank you, Dr. Prashad. One more question is there. So the question is, besides sugar control, what other preventive measures can be ensured by the patient to maintain foot care?
See, of course, when we are talking about diabetes, it's not just about blood sugar, right? As we are already aware nowadays, it's a holistic approach, which we need to take care of for patient's blood pressure. We need to take care of patient's lipids. We have to take care of patient's heart. We have to take care of patient's kidneys also. I mean, kidneys are not, I mean, as a directly, but indirectly, of course, all the organs are affected. So we have to take care of all those. Then patient has to do for the regular diet and exercise that we have to do. We have to inspect the patient's feet daily. And moreover, not just we have to observe, inspect the feet, ask your patient to inspect their feet daily basis, right? And whenever they see any difference or anything, consult you first. Yeah.
Thank you, Dr. Prashant. Sir, one more question is there. How frequently foot should be examined in clinic?
Ideally, it should be examined at each and every visit. So whenever your patient is coming to you, please check their feet every time.
Thank you, sir. So one more question is there. Is there any role of methylcobalamin in prevention of neuropathy and foot problems associated with it?
See, as I told earlier also, see, methylcobalamin, there are various papers which says, yes, there is a clear-cut role of methylcobalamin especially in patients who are deficient. So if there is a deficiency of methylcobalamin, giving methylcobalamin supplementation always helps out, and it can actually have an impact on prevention of the diabetic foot neuropathy, and also it can reduce the progression of the disease. But what we have to understand is that giving methylcobalamin after the disease had set up may not have that much of impact. Of course, it will help in reduction in progression, but ideally it should be started in patient on an early stage, means when the diabetes is diagnosed, at that time it should be started. Patient should be prescribed vitamin B12.
Thank you so much, Dr. Prashant, for giving your valuable time today. And we thank you all the delegates for joining the session. So here we end the session, and thanks once again on the behalf of Mental Pharma. Thank you, sir. Thank you.